All right, good afternoon, everyone. We recognize that you are taking some very valuable time to spend with us today, and we want to make sure that that is time very well spent. And we're really excited about today's event, Practical Methods for Improving Care Coordination for Cardiac Rehabilitation Patients. It's lovely to be talking about the nuts and bolts of how you best support your cardiac rehab patients instead of talking about how all of the challenges associated with COVID. So we're delighted that we're moving back into the main focus of Take Heart and are really excited about the presentation today. Before we move into today's event, I just wanted to let you know that we've got some additional opportunities for Take Heart coming up that we'll be telling you more about. There is going to be a focused Take Heart additional cohort that will be shortened and focused primarily on care coordination. And if you have any interest in that, we'll be sharing information with you about that quite shortly. And then there's also going to be a special focused work group of programs that are directly involved with the use of hybrid cardiac rehab, either in the planning stages or already implementing or getting ready to implement. And that will be a small group, but they will be working together, sharing together, and ultimately creating resources that will be more broadly applicable, that will help many other programs that are interested in using hybrid to better support their patients. So those things are coming up, and we'll say more about the next affinity group at the end of today's session. But let's move now to remind you that we want these events to be as interactive as possible. And the best way to do that is by using the chat function. So you need to open the chat box and type in your question or comment. We love to see questions or comments. You can make them, but try to set the to field to everyone. So that will come to the panelists as well as to your peers. And very frequently, it's your peers that may respond back to you in addition to the panelists. So we encourage you to use the chat, and throughout the today's event, Hisham and the panelists will be reacting to any questions or comments that are put in the chat in response to the content that our panelists are sharing with you. We also want to do one polling question at the start of this event. And in just a second, we'll display this. But if you can go on the right-hand side of what you'll see on this next slide and tell us what you think about your biggest challenges associated with care coordination. So as we look at that slide, which part of the care coordination process does your program struggle with the most? I'm not saying that you're struggling, but every process has easier or harder parts to it. So take a second and choose one of the four options that you see there. Is it making the initial patient contact and encouraging them to agree to enroll in your cardiac rehab program, or getting patients that agree to enroll to actually show up to that critical first session, or getting patients that attend one session to come back for more? Or once they've come to a couple, keeping them going through the entire 36 sessions or whichever number has been prescribed to them. So take a second and respond to based on which of those options you see as the biggest challenge for your program. And then I think that you've had time to do that, so we can go ahead and close the poll. And in just a second, we will see the responses come up yet, and then I'll ask Hisham what he thinks of whether there are any surprises in those responses once the results are displayed. And they should be coming up just in a second here. With the Take Heart hospitals that we've been working with more extensively, that have been working on care coordination over the past year, I think that probably among them, it's the initial contact and getting them to enroll in the first visit, that they would probably have made their priority. But over time, as you improve in one area, then you start to see the opportunities for improving in others as well. So I don't know. Apparently, the new system does not display the results, which I didn't realize. Oh, here we go. We've got this displayed, and it looks like pretty even. Once you get them in, it looks like you can get them to come back for a second time, but getting them to keep on coming, that's 30%. The initial patient contact is 30%. Getting them to agree to come to that first session, that seems to be the most common answer. Hisham, any surprises to that, or is that about what you would have guessed if we had you make a prediction in advance?
Well, they're all the answers are very close to each other. We only had 20 people answer this because people were still logging in. We're above 85 people logged in already now, but I think that's fairly it's a fair assessment that a lot of people, will make their contact and promise to come and then and to enroll, and then eventually they don't come in, and then once they come in the first time, it's hard it's challenges to keep them coming and then to eventually complete. But so, those are challenges that you would see at every step of the way.
All right, thanks very much. And our three panelists today will have the opportunity to give you good advice on each of those phases in the process. And I'd like to introduce them now. You've already met Hisham Skali, who's the Take Heart Principal Investigator and the Associate Director of the Cardiac Rehab Program at Brigham and Women's, and the longtime facilitator of these events. And then we also have Stacy Greenway, who's the Director of Cardiovascular Disease Management Programs at Vidant Medical Center. And then Virginia Morris, who's the Director of Rehab and Cardiopulmonary Rehab at MedStar Southern Maryland Hospital and MedStar St. Mary's Hospital, two of the MedStar hospitals. And then Kathy Briggs, who's the Director of Cardiac and Pulmonary Rehabilitation Services, just recently resuming their pulmonary rehab services at the Eastern Alabama Medical Center. So 3 panelists with great insights. And at this point, I'm going to turn it over to Hisham to guide us through the discussion that follows.
Thank you, Steve. And I want to thank again our panelists, Stacy, Virginia, and Kathy. Thank you very much for joining us and sharing your insights and also your experience with Take Heart so far. I think what would be good to start is really just to put us in the mood, is tell us about what is your program like, and when you joined Take Heart, and why you decided to participate in Take Heart, so that we have a lot of participants and try to connect with your experiences. And maybe I'll start from my screen, left to right. I'll start with Kathy.
Sure. Good afternoon, or maybe good morning for some of y'all. We're afternoon here. I'm in the Auburn, Alabama area. Actually, Auburn and the hospital is in Opelika. And as was mentioned, I direct cardiac rehab, and just recently was given the duty to, I'll call it, resurrect our pulmonary rehab program that closed during COVID, and now we're reopened. So I'm happy to have that going again. I arrived here in 1999, and back then we had a little bit of inpatient, I'll call it inpatient cardiac rehab. We had someone who would go up on the floor. So we've had some care coordination for a long period of time, but it really hasn't been very well structured. And so what this participation in Take Heart has really allowed us to do is solidify that, structure it, give it some more oomph. The opportunity to participate allowed us to look at how many patients we were capturing from inpatient to outpatient, look at those numbers, realize that we weren't doing very well. Historically, we were only 15 to 20% capturing of eligible patients. So this allowed us to deep dive into our processes and really look for improvement opportunities. So Take Heart has been a wonderful opportunity, and I greatly appreciate being able to participate.
Thank you, Kathy. And Stacy, how about you? Where were you? What was your program like? And tell us about your experience with Take Heart. Thank you.
Sure. So Vidant Medical Center is located in Greenville, North Carolina. We're a health system that has 6 cardiac and pulmonary rehab programs throughout the system. I have 2 of those that I manage. One is a hospital outpatient-based program, and the other actually is a physician-based program, which has been interesting. In terms of the decision to participate in Take Heart, honestly, the biggest was just opportunities to learn about how to improve our processes, both from an efficiency standpoint as well as a patient satisfaction. So many different reasons that I think our program benefited. But honestly, the guidance of looking at our flow, our workflow, mapping that out, and then from the perspective of data and having Take Heart be the reason as to why. So we really got a lot more buy-in as to why we were looking for the data that we were, and being a part of Take Heart kind of strengthened that ask.
Great, thank you. And Virginia?
Hi, everyone. As mentioned, I'm the director of the cardiopulmonary rehab departments at 2 of the MedStar sites. Both of them are hospital-based sites. St. Mary's is a bit more of a rural community, and so our programs are relatively small. The St. Mary's program is quite small. And one of the reasons that we really wanted to get involved in Take Heart was to increase our referrals and our participation in the program. I apologize, there's jets flying overhead, so I don't know if you can hear them or not. They're quite loud. We really wanted to increase our referrals and increase our attrition, because we had a lot of problems keeping patients in the program. So that's really what drove us to become part of the Take Heart program. And then that collaboration with other programs. We were really interested in collaborating with others and learning from others. And then I think kind of along the lines of what Stacy was saying, I think the data became really important for us as well. So really, as we went through the program, understanding the process mapping and the data, and how we could really make the data work for us has been invaluable.
Great. So thank you, guys. And then I think a lot of great words there: process mapping, data, collaboration, learning, and this is all what Take Heart is about. So this is what we're going to be talking about throughout the next 40 minutes or so. We're going to talk about your experiences with process mapping and how you collected your data and how it affected your approach to care coordination. What are the biggest positives and learnings that you got through with this, and then what were the challenges? Because in every experience, we know there are challenges and obstacles that we have to overcome, and I'm sure you did great at that. So we're going to learn from those, and then eventually at the end we'll conclude by talking about what remains to be done and what final advice you would share with us and with our participants. Thank you. So let's start with this. What do you consider a successful process mapping? I want to hear about your experiences with, what is it you included, how you made it work.
I'll go ahead and start since I was first up. I am very, very fortunate. Our hospital has a process management department. So one of my first reach outs when we started with Take Heart was to reach out to that program, because I knew that they would be invaluable to me. So I reached out to the process management department, and I was fortunate to have a staff member assigned to help me a little bit with this. And she took us through a process mapping procedure. And it really was, I've process mapped before, but my staff had not. So it was very unfamiliar, and it actually was a little bit painful for them because, when you're process mapping, you really have to think of every single step along the way. And they're very task driven and don't necessarily always know what the process is. They know what the tasks are and what order they typically go in. So it was a great process to do some mapping And it did help us to identify some gaps that we didn't realize were there. It helped us to see some great opportunities for improvement. For example, our consult to cardiac rehab that we have in Cerner, we found was dropping off for some of our CT surgery patients. We didn't even know it was dropping off. So it really, the whole process mapping effort was very, I feel very successful. Now we do plan to do some more. I definitely want to map our patient journey because I think that will tell us a lot also and give us some more opportunities for improvement.
Excellent. Yeah. So when you deep dive into it, you find things that you were not expecting. Virginia?
Yeah, so similar experience to Kathy. Really, it was a great experience. We did not have we didn't have the benefit of having someone to help us, unfortunately. So we had to sort of figure it out by ourselves. But I will say that the Take Heart resources were exceptionally valuable. So we used the learning modules and we used the implementation guide to help us work through the process. And what we found was that everyone had a different understanding of what the process was. So it was a really great exercise in getting us all together and really understanding all the pieces of the process and recognizing that there were things that were happening in certain parts of the process that maybe some people weren't as familiar with. And we did actually engage a patient. We were able to take our process map to a patient, and we sat down with a patient and mapped their experience, and that was a real eye-opener as well. And so one of the things that was a real aha moment for me was recognizing that we were losing a lot of patients to follow up. So our process almost had like a cliff at the end of it that kind of fell off at the end, and we recognized that we definitely had some opportunity there to sort of fill in that gap. So it was a great experience.
Good. Stacy?
I can definitely reflect the same. The toolkit was great to help lead us through. I have to say, Kathy, kudos for involving another department. Honestly, I think those of us in cardiac and pulmonary rehab need to be reminded that there are resources within our hospital and to reach out and ask. Because I honestly didn't even think to look at our quality improvement folks. So kudos on that. The toolkit was great. We did the same in terms of not only going through it with the staff that were involved with that part of the process, but also involved the patient as well. And honestly, that was where some of the biggest feedback was, because when they are not in our own mapping, we found that there was a delay in initial communication. And for us, that was based on the fact that we weren't ready to enroll them. But for the patient, that gap of information from the time in their AVS or their after visit summary, they say, you've been referred to cardiac rehab, to first contact was off-putting for the patient. They were expecting fairly quick communication. So that was a big one for us to be able to fill in that gap and make sure that we were communicating in a timely manner. And that was, I think, very helpful, and have subsequently seen some good responses from patients in regards to that. But definitely a good experience. Something that I think we'd like to do on a regular basis, just to make sure that we're not we identify gaps as they occur versus, oh, we didn't know that was happening.
Yeah, can I just add as well? So what Stacy, what you were saying there in terms of the gap with communication, that's interesting because we experienced something similar when we spoke with the patient, but it was the reverse. We found out that the cardiologist was telling patients they needed to wait 4 to 6 weeks before coming to cardiac rehab, and we were like, oh, that's why we're having such a hard time getting people in sooner. So it was definitely enlightening for sure.
And I'll chime back in on the tools from Take Heart. My process management staff person really appreciated having those because that gave her a good starting point, because she really wasn't familiar with cardiac and pulmonary rehab, well, cardiac rehab at that point. And so those tools gave her a nice starting point. So kudos to Take Heart for developing those.
Thank you, Kathy. Yeah, no, I think that's one of the main lessons is that you can have experts at process mapping and experts at cardiac rehab, but you really need to put them around the same table to make it work. And then you need that feedback between your referring providers and then your patients to make it all work. And that leads us to the next section, is that once you try to get all these people around the table and your patients and yourselves and so on, is what kind of data are you trying to collect, and how do you evaluate that data? And so let's start with you, Stacy, to tell us about what data did you collect, how did you review them, and what did you learn from that?
Sure. That honestly, as I mentioned in the intro, is probably the most exciting, and I didn't even realize I enjoyed data as much as I do, because we have it and it's complete. Not only were we able to allow this project to help drive data collection for my own programs, but actually it was a system-wide effort. So now the other program managers throughout our health system are able to look at how many referrals are coming in. Of those referrals, how many are then being assessed, and then further on, how many sessions they attended and whether they completed the program as well. Rather than doing averages or having to collect manually, it is an automated report that comes right out of, we're Epic, are coming right out of Epic, and then can be exported and analyzed through Excel. It's been so powerful, and honestly, some of the things that you assumed were the case were not. And some things that you didn't expect we're able to look at as well. So it's really been excellent to be able to track that. We do that on a monthly basis. It's actually something that is now being brought to our service line, our heart and vascular service line committees, so that they're aware of what's going on. And honestly, the cardiologists were really excited to be able to see what was going on and be able to provide input from their own perspective. And that, I think we're all part of the same system, but sometimes those silos occur even within pieces of a same service line. So that's been very helpful.
Excellent. And thank you for mentioning you were Epic. I was going to ask you that because I want to hear, and want our attendees to know that we can do this with, whether it's Epic, Cerner, or any other EHR. You can dig into it and figure out the data that you need, and then collate it and analyze it in the way you want. Kathy, tell us about your experience with data.
I'm probably the weakest of the three where data collection is concerned, because we do a lot of manual counting, and always have. I've always known data was important. I've counted things, but haven't had mechanisms to count. And I'm still, that is our ongoing performance improvement, is figuring out how we can automate the data collection, and being involved with, with the collaboration with everyone. That has given me some great ideas, how to be more efficient, because it's time consuming for the staff to, if some of them may be on the line and they're probably shaking their heads going, yes, we hate to do those, I call them the tick counts. But that's how we get some of our, data. And so that has been a challenge for us. We've gotten a little bit better, but we still have a ways to go.
Great, thank you. No, I think it's important. Have you reached out to your QI people in terms of trying to automate that data collection and gathering?
Yes, and I had a QI person on our Take Heart committee. They've been a little absorbed in other more important things during the last 2 years, I'll say that. So I think
Yes.
opportunity is probably a little bit better now. I'll be readdressing it and kind of circling back with some of those folks to ask for more. But yes, thank you.
And how about you, Virginia?
Right. So I would say I'm somewhere in the middle. So I think that was definitely one of the strongest ways we came through Take Heart, was with the data and identifying what data we needed and how to collect some of the data. So we were able to get a report built from our emergency department of all eligible patients that hit our ED, just to give us a general sense of, like, within our community, how many people would be potentially eligible for cardiac rehab versus how many referrals we're actually getting. So just kind of getting some information there. We've been able to leverage ScotCare and pull some data from ScotCare on demographics and some basics related to that. We part of it is also leveraging the EMR so that you can then pull the data, right? Because it's making sure that it goes into the EMR in a way that you can then pull it into a report. We're on Cerner. So we developed some documentation related to our automated referrals that will be much easier to then get a report created on. So we'll be able to start tracking that information. So we're still evolving in terms of how we are pulling it, but we definitely made some really nice progress.
Good. And you said you were using Cerner, right?
Yeah.
Good. All right. So we have like a whole spectrum there of Epic and Cerner. How about you, Kathy? What
I wanted to chime in to mention we're LSI and we're Cerner. And unfortunately, I've been asking for many years for an interface, and it's still on every year. I re-request in the capital budget. I still haven't gotten it yet, but someday we will get it. But I will say the AACVPR registry is a great source of data that our LSI system does interface directly with the AACVPR National Registry. And you can get your individual program data as well as comparison to state and similar size and national organizations. And that has been helpful to be able to use those resources.
Yeah, absolutely. I think AACVPR registry is a great resource. And just if it's any consolation, the interface between LSI or any other provider and your EMR is not always easy. So I'm sure you're not the only one out there with that. Yeah, so once you have that data and you've implemented some of the care coordination changes there, I'd like to hear from you. What is it that worked? What were the biggest, the changes that you noticed and best impact, and what made you really happy and excited about what you implemented? Virginia.
All right, I'll take it away. So I still feel like we have a long road ahead. I think the thing that got us most excited was actually the data and showing us sort of where we were. We didn't understand where we were in terms of our participation and attendance and graduations and those types of things. So just really understanding where we were. We've coordinated with our inpatient unit. We already had a pretty solid automated referral in place at Southern Maryland Hospital, but what we are trying to do is coordinate with the unit and the nursing staff and the medical staff to really help bridge the gap. Because what we were finding was even though patients were getting referred, we would call them and they still haven't heard of cardiac rehab. They didn't know what we were talking about. So trying to really bridge that gap. But I do think our process in responding to automated referrals has become more robust. We are much more, we're able to get in contact with these patients earlier. And now we have some pretty strong documentation to start tracking potential barriers early on so that we can start addressing those barriers to getting them in. So those are the pieces that I think we're most excited about. We are engaging outpatient case management as well to see if they can help with that follow-up, because we've got a lot of patients that we tend to just kind of lose to follow up. So we really want to make sure that we're circling back around to them.
Very good. And Stacy?
Sure. I think the first bullet point to me is so huge. I think with this process and with any new process, we went back to the staff and said, suggestions. If you're isolating an issue, or if you're seeing something that's not normal or out of ordinary, please bring it to us. Don't just assume that it's a one-time thing and it's a blip on a screen and just move forward. And so I think as a result of the open communication and making sure that the staff know that we want to know what issues they're running into, we were able to identify some things that may have just been something that they just developed into a workaround. And so as a result of that, our referral coordinator, the person who does a lot of our coordination for our own program as well as in the region, identified that there was a number of patients that were just kind of going into a black hole where the provider would call and say, I put in a referral, but no one's responded to it. And what we realized that the referral was built, and it was basically intended, well, not just intended, but they built it when I asked for a referral to be built for the inpatient environment. And that that automatically falls to our work queue, and we disseminate it out into our own referral work queue or to another programs within our system. And what we found was that same referral was being picked up by the ambulatory physician practices. And unfortunately, that referral wasn't falling to that work queue. We would never have discovered that if someone hadn't brought it to us. We would have just assumed that we were capturing all the ones that we were going to get. Now, certainly the opportunity, Virginia, kudos to you for being able to get the identification of all patients who are eligible. We're still working on that from a data perspective. That would have captured it from that, but we don't have that yet. So I think I encourage anybody who's looking at changes to really involve your staff and let them know that you don't have all the answers. And it's an evolving process. And if they identify something, not to just accept it and shrug their shoulders and say, oh, well, they must have meant for that to happen or whatever the case, but to really bring it up and allow you to dig into it and find out, because a lot of times there's a cause that you can usually fix.
Yeah, no, I think that's absolutely, that's important. And so those referrals that you realized were not coming through, they were going to the ambulatory practices and they never made it to your list. So that's why you never called them.
The ambulatory practice would put the referral in, and because the way that it was built, it wouldn't have anywhere to land. And so it just stayed with the chart. There was also an instance where the referral coordinators in the ambulatory clinics would enter in the referral, and then they would mark it as complete because they had done their job, not understanding that when you complete a referral, it stops. It shows that it's been completed. And so even that small little change, that was just from one of our pulmonary department or clinics or pulmonology clinics. And so all these referrals for all these pulmonary patients were never going anywhere. And then they would call us upset because we hadn't called the patient and we didn't even know a referral existed because of their workflow. But having the IS contact that had originally built the referrals for us has been huge. She, unfortunately for her, is our go-to person to say, we're running into a problem, can you help us dig? So those sorts of things that we might have glossed over and just thought, oh, well, now we have the contact to call, and then you contact the clinic and have just a little conversation about how we can help patients.
But so you had to contact those providers and then help them correct that workflow so that those things didn't end up in a black hole. Okay, very good. Kathy, what was the biggest change, the change that you made that led to the biggest impact on your care coordination?
Well, first I want to chime in on what Stacy just said. It's funny because I was standing in one of our pulmonologist office. I was, as I'm starting this program, I'm interacting with them in their office off and on. And he was saying, I just saw this patient that I referred to you in pulmonary rehab. And I said, I haven't seen that one. So we stood at his computer and he showed me the clicks and the steps that he had done. And we realized, same that you found out, they're going into a black hole. So that's on the to-do list to work on that. So it's interesting, how when you dig in or accidentally are in a situation, you find these gaps. But I will say we are very fortunate. When they were building Cerner and they were building power plants and things like that, I was around and I was able to put consult to cardiac rehab as a task on quite a few of our, like the PCI and some of those standing order sets. So we've had that process in place, but what we've done during Take Heart, we went back and we reviewed all those power plants, made sure, yes, it was still on there. And we also have a heart failure readmission team that was working on a plan for our heart failure patients while they're inpatient. And I was involved on that team, so was very fortunate to be able to raise my hand and say, hey, consult to cardiac rehab needs to go on those orders. And it also enabled me to have the audience there were cardiologists on that team, there were hospitalists on that team, the care coordinators were on that team. So you know, nursing staff, obviously, social work, I mean, think about pharmacy. So a lot of departments throughout the hospital realized what cardiac rehab is and what it can do for their patients as far as decreasing readmissions if we coordinate and if we get these consults so that we can touch these patients. So I think, you know, we've really made some just little minor changes, but in the long run, major changes for our patients. And back to, you know, the listening and acting on staff suggestions. I mean, anytime the staff say, oh, this form doesn't really, you know, I overhear them talking about, oh, when I'm documenting on this, it doesn't do that. We grab that. I've started grabbing that, and we have another great department in the hospital. If you haven't ever interacted with them, it's one of our MIS type of departments. It's called application support. They helped so much, and they are the ones who can help you when you're automating processes in your EMR. And they now know, they know about cardiac and pulmonary rehab through our Take Heart efforts.
So yeah, no, that's important. I think it's one of the modules from Take Heart. I think we had Dr. Amy Miller talking about, you know, implementation of the automatic referral, and one of the things that she says was like, you have to work in your testing environment, and you have to test and retest and retest, and so that's how you continue to track whether any of those referrals fall in the black hole. Are there any differences in the mapping between patients who are referred from an outpatient ambulatory practice versus those who are coming in from an inpatient setting? And then, as you said, it could be something as minor as someone clicking complete, and then that whole referral, that whole patient is actually completely discarded as opposed to being acted upon. So I think that's important. And so I want to get back to what Virginia said in the beginning, looking at that denominator of like all the eligible patients in the emergency room, for example, with those eligible diagnoses. Have you found a difference, or have you looked at whether patients present in the emergency room versus other settings such as ambulatory practices or inpatient settings or anything else that allowed you to say, well, we should stick with this, or do we need to change our data collection? Should we consider another environment or another clinical setting?
So for now, we're kind of really looking at who's coming to the emergency department. And then the report also tells us where they went. So the report will tell us whether they were admitted to inpatient, whether they were discharged home, or whether they were transferred up to another higher level of care. But we do recognize that there are some patients that come up to our hospital, to our cath lab. They go straight into the cath lab, and they bypass the emergency department. But we also are hoping, we haven't managed to get a report on them, but we're also hoping that most of them are caught by our automated referral process, because most of our AR comes from the cath lab, from patients who have procedures done in the cath lab. So we felt pretty comfortable that the majority of the folks that we needed to see through the cath lab we were getting. But absolutely, I think a huge piece that is missing for us that we just need to figure out is how do we collaborate and coordinate with the cardiologists in the community and the PCPs in the community, and tap into patients out there. I feel like we're a little bit more robust when it comes to our MI patients, our patients who are having cardiac procedures. But our heart failure patients, there's a gap, absolutely. We do have a heart failure clinic that just started up, and we have started engaging with them to try to figure out some processes around how do we tap into those patients and get them before they start having multiple readmissions. So definitely some more work to come for sure.
Great, thank you. So I'd like to remind everyone and the attendees, which are nearly 100 people now, which is amazing, to use the chat box. If they have any questions or comments, we'd be happy to address those. We have one actually very good question from Haley Stolp, our colleague and friend from the CDC. Would it be meaningful to have a regular quality control check to be sure no referrals are lost to the black hole? I think it's important. So, you know, how have you guys put in place this quality control, this test, retest, figuring out like all the referrals that come in, how many actually are acted upon and how many are actually closed and ignored. How did you guys do that? Is it part of your care coordination? Is it part of another process? How do you check that, Stacy?
I think honestly, our first step is to close the data gap, and that is the identification of patients that would qualify. So that's when we're able to do that. To be honest with you, yes, it would be do we have a one-for-one relationship? Do we have a patient who is eligible but then doesn't have a subsequent referral as part of? Right now, the focus is on inpatient. We often get ambulatory referrals within the same work queue, and those always match up. If someone's have CT surgery, usually we get one inpatient, and then there's a follow-up if they haven't been enrolled by the time that they see their CT surgeon. They're fantastic as far as doing that follow-up. But I think to your point, and to Haley's point, absolutely, I think there's a lot of opportunity for QI to say, is there a one-for-one relationship, or do we need to maybe see who that provider is or what that group is that maybe is missing the mark. It's been very helpful to have our referral as part of an order set that is used by the majority of our cardiologists that practice within our facility. That's been very helpful. We are also aware of a couple of providers that do not. And so because we already are aware of that, we do some marketing there.
Good.
I'd like to share, we have, and I forget when we developed this, we get a daily report. It comes via email, and I can't remember how we developed that. It was through, it's a report of PCIs done yesterday in the cath lab. And so that allows us to double check for, theoretically, we're getting a consult to cardiac rehab task to see those patients, but that Excel spreadsheet, the staff double checks to the consults for PCIs to make sure that nobody fell through the gaps on PCIs. For CT surgery, we're pretty good at that because we actually do a pre-op education session with all the CT surgery patients. We have a very tight relationship with our CT surgery surgeons, and they have included us in their process. They have verbalized, both surgeons have verbalized to me, I want 100% of my patients in cardiac rehab. So they have always, I'll say, played well with us to help us to get all of their patients. So we've got processes in place for PCIs and CT surgery patients, but the MIs and the other diagnoses, we need to figure out how we can do some quality control on catching those patients for sure.
Yeah, it all goes back to data collection and trying to figure out where is that gap. Great. So in the interest of time, I'm going to move to the next step, and I think that's where we were just talking about. Also, is that what are some of the challenges and some of the strategies to overcome those challenges that you encountered during this whole process of process mapping and care coordination. And obviously within the last 2 years, we know that we had a lot more than our usual work. So Virginia, would you like to start and tell us your experience?
Sure, this is an easy question to answer. So as you mentioned, I think the last 2 years has posed a number of challenges. Obviously, none of us saw coming. But I think one of the biggest challenges for us was because we had an automated referral process in place, and we would have someone go up to the floors to see patients while they were still in the hospital. We stopped that obviously with the pandemic, and we have not gotten back to that. So I think that is a great opportunity, because I do think that personal connection just makes such a difference, and I think it helps the patients, put a face to a name, see someone, ask their questions, and hopefully feel more engaged and more motivated to participate. And then, you mentioned the staffing challenges. I still have staff that are redeployed, because I have an RT in my department, and RTs are really hot right now. And so, she's working mostly on the inpatient side. And so having the staff to be able to do all of the extra things. And, as we were talking earlier about the data, it's great to get all these automated reports, but someone still has to do something with them. And so it's identifying like who's going to have the time, and who's that person that's going to be the person that sits down and actually makes the data have some meaning, and then do something with it. So those are probably our biggest challenges. And then I would say the last challenge for us is, we went into this wanting to grow our referrals, to bring more patients in, knowing that there's such a huge utilization of cardiac rehab, but we are limited because we have to still maintain physical distancing, and so we have limits in terms of how many people we can actually bring into our program. So we've got wait lists. We can't, so we're sort of, pushing on the edges, and trying really hard to figure out how do we grow when we can't grow, if that makes sense.
Yeah, absolutely. It's probably a challenge that's encountered by a lot of people and a lot of programs, especially when your staff is redeployed somewhere else in other areas of the hospital, or you have to reduce your FTE, or you have to reduce your class sizes, and so on. But I think that's certainly felt by a lot of people. I think one of the questions that came through the chat box here is, do you tap, and Virginia, you said you sent some of your staff to talk to the patients while they're still in the hospital, but if you don't do that, one of the questions here is, do you tap on the local care managers who are on the floor and so on? Do you enlist their help for emphasizing the importance of cardiac rehab and referral and enrollment?
So we try. That has had its own challenges. Our care management team, our case management team, are very stretched, and actually at Southern Maryland, most of our case managers are travelers, so they're struggling with the staffing issues just like everybody else is. We have met with the nursing staff and provided some training with the nursing staff. But I think that's a really great point. And that is something that we see as an opportunity, is just how do we engage the team on the unit to really be able to sell this as well, and really encourage and promote this with the patients while they're there.
Yeah, absolutely. Kathy, any challenges you'd like to share with us and how you overcame that?
Actually, I only have 7 staff. 2 of the nurses were basically deployed throughout the majority of the pandemic. So we had major staffing challenges, I'll say that. But, the staff that remained, which was primarily exercise physiologists, really rose to the challenge, did a great job. We also, like Virginia, discontinued going up to the floors for our inpatient visits. And we've gone back to that, but there were some things that we have kept. Like we're doing a lot more telephone contact with inpatients than we did in the past. But I have one staff member who was new to cardiac rehab at the beginning of the pandemic, and then got deployed back up to her old department, which was the cardiac floor, 2nd floor. And she's 20 plus years in nursing and cardiology. She has great perspective on how to I'll call it convince a patient to move from inpatient to outpatient, and she has been a great asset to the staff, and she's really the best at, I'll call it, selling cardiac rehab. But we staffing is always a challenge in our departments, because we're the small ones that don't necessarily always get all the attention, and we're held, I know, we're held to some pretty tight financials. So it's you do the best you can with what you have, and I think the staff really has rose to the challenge during the last 2 years. They've done a great job.
in regards to the question that you asked earlier, as far as talking with case management and care coordination, what we found is if we can get on their agenda, the case managers throughout the organization have a regular meeting just to have updates about their workflow and what's going on. And I try to ping them about once a year just to say, remember, remember that we're here. Can we have a 5-10 minutes to talk about what we do? You know, they are typically always open to resources, and oh yeah, I forgot, that's a great option. So I think it's trying to stay on top of mind for those that are at the table when you're not able to be. That's been very helpful to us. Same thing with our physical medicine residents. We have an inpatient rehab, and I asked to be on their agenda about once a year. So as those incoming residents and fellows come into the program, again, they can be an advocate for us. As far as the staff challenging, I would love to talk to someone in rehab who can't say yes. that it didn't impact me at all. I don't know what y'all are talking about. So we actually had an inpatient care coordination person that was part-time. She actually retired prior to the pandemic, and then of course the pandemic hit and increased the challenge. So much like Kathy was saying, we do a lot of phone orientation. We've talked about, now that we're in another place, I'm not going to say things are over, but in another place in this journey of COVID, we are looking at possibly having a orientation option for people to come learn about the program if they're interested. We've had two sets of populations of patients, some that want it speedy and quick and phone is fine with them, and then there are some that really want to dig in a little deeper and meet the staff and see the place. And so having two option, I think, is one of the things that we've talked about, because honestly, to Virginia's point, having that personal connection is really huge. I think when we were teaching a pre-discharge class to our CT surgery patients, that connection with the family members and patients really had a tremendous impact on those that would convert, those who'd been referred that actually enrolled. So that's something that we'd like to get back to, but dealing with the challenges of staffing and that sort of thing is certainly a part of it. So it's an evolution for all of us, I think.
Yeah, absolutely.
Sorry, go on.
I think that's a great point. And so certainly I don't have any miracle about staffing, and it's been challenging for everyone. But what you mentioned about like getting on the agenda for the care coordinators or case management meetings, or the physician assistants in the cardiac surgery department or in the cath lab, we have been doing that regularly. I mean, you meet with one group every 3 or 4 months, and so you'd meet with one particular group every year, or maybe twice a year. I think that often brings back cardiac rehab and bring cardiac rehab referral, and who are the people working in the cardiac rehab department, and puts a name on a face and so on both sides. I think it's an important strategy to keep cardiac rehab present in the inpatient setting, especially for programs who are not on site at the same place in the hospital setting, and just next door, or maybe a couple of streets over, or maybe a couple of towns over. So it's always important to stay there, to stay present. Good. And so in the last few minutes, I'd like to still benefit from your insights and sharing. And what would you like to see happening in the next several months and year? What is your top priority, and what would you like to share with our peers? Kathy, you want to start for the last question?
Sure. I already mentioned, for as far as a top priority is some more mapping, some more data collection, definitely mapping the patient's journey, because I do think that, looking at our processes and our coordination from the patient's perspective will give us some more gaps and some more issues that we want to, that we want to look at. As far as advice for everyone, I really think be patient, be persistent. We all know Rome wasn't built in a day. And so neither was care coordination. I've been at my hospital since 1999. And, you know, at the beginning, I mentioned there was somebody going and seeing inpatients. So we've been building this for 20 plus years, and I still see lots of opportunities for improvement. And I think, you know, care coordination is just an ongoing process that is ever changing. And so be persistent.
And persistence is a key feature, and resilience is a key feature of cardiac rehab. So I thank you for reminding us about that. Virginia?
So our priorities next are to engage our outpatient case managers to see if they can help with some of the follow-up and addressing some of the barriers to getting patients to participate in cardiac rehab. And then, as you mentioned, Hisham, really engaging with some of the key groups. We want to get a cadence around being at the table on a regular basis and kind of being in their face and like reminding them that we're there and reminding them what qualifies and just making sure that they understand the process. So those are probably the two big priorities for us as we move forward. And then in terms of advice, I would agree with Kathy. I think it's just be patient, be persistent. And I think, start small. I always say, how do you eat an elephant? And it's just, take that one bite at a time and just start small and then just sort of tackle one issue as it goes.
Nice.
I think for us, it's definitely revisiting the idea of care coordination because our system serves about 21 counties. We have reason to understand that that's a lot of patients that we potentially can impact and have that touch point. So revisiting that, looking at whether we could make that work and what that would mean in the long term, although it's kind of soft dollars as far as that's not a billable visit. But what would that mean for driving enrollment, even if it was a pilot? So now that we are able to capture the number or the percentage of patients that we are capturing for enrollment, if we could do a pilot with an inpatient person, and what would that look like? That's kind of one of the things on the horizon. And then as far as advice, go into this process open-minded. Admittedly, I've been in rehab for 20 years, and at first when the process mapping came up, I thought, oh, what could I possibly learn from this? Never make assumptions. There's always things to learn. There's always parts of a process that, unless you're intimately involved in it, you don't really understand it, and you really need all those intimate knowledge bases to be able to come together to truly understand it. So go through with an open mind. And recognize, as everybody else has already said, small little improvements can make the biggest difference and honestly excite you for the next phase. Learn a little something, change a little something, and then go forward from there. And then the other piece, the final advice would be involve your patients. Involve your patients in the process, bounce ideas off of them, even if it's an anecdotal conversation with a couple patients. Hey, what do you think? We make so many assumptions about what their care is and what they want or what we think that they want. And unfortunately, sometimes it sends us down the wrong path. So have them at the table.
Very nice. And that's a very nice way to conclude this. Bring back the patient to the center of the discussion and involve them. So thank you. And with that, I'd like to return this to Stephen, and thank you, all of you, for your insights and sharing your experiences and your hopes. Thanks, Stephen.
Thanks very much. And thanks, as Hisham said, to our panelists who had some great insights, great practical advice on care coordination that we hope will resonate with you in your programs. We want to encourage you, and thanks to those of you that submitted questions and comments in the chat as well. But we want to call attention to a couple things as we wrap up this afternoon. You'll see some questions, just some feedback questions that will pop up, and we'd appreciate it if you could respond to those questions. The event materials from today will be shared with all of you in the next couple of weeks. And you can find the information about Take Heart's care coordination activities on the Take Heart website. We encourage you to go there. There's a wealth of information in those. We are working on the next affinity group session, and we expect to be able to announce the date and the time of that shortly. For those of you that are interested in automatic referral, we are having a Q&A session that focuses on Epic. So if you're using Epic and you're interested in automatic referral, that Q&A session is going to be on April 27th from 2 to 3 Eastern time. And you'll get an email about that later this week as well. So any additional suggestions that you have for us beyond the polling questions that you're seeing now, we welcome that from you. And I want to thank you all for your time this afternoon. Thank our panelists again for their great insights, and we hope that you have a great rest of your day and a great rest of your week.